Thank you, Dr. Holtzman. I think since we hear again and again from our patients that the scars that are left from surgery are one of the principal concerns that patients all have, the message is less is more. Surgery in 2013 and 14 is smaller than surgery was 10 and 20 and 30 years ago. It's more precise, it's selective. So the lymph node you take out is the one that is pivotal, is the one that will tell you whether the risk is or isn't there for anything further. So what further? So the next talk we will have an opportunity to hear today is on the enlarging role of immunotherapy in melanoma, an option that has had its principal role in the adjuvant treatment and the treatment of advanced disease. And Dr. Tarhini will present this today to update you on what is there for the existing immunotherapies we have, both in metastatic disease and in the adjuvant therapy of this disease. Welcome, Ahmad.
Thank you, John. I'm grateful to you and to Val for giving me this opportunity to talk to our patients today. Without further introductions, as John noted, we'll be talking about the enlarging role of immunotherapy in the treatment of melanoma, which is a very exciting field at very exciting times for us, with a lot of advances that makes us very optimistic about the future of treating more advanced stages of melanoma. So my talk will be divided on two major sections, immunotherapy for metastatic disease and immunotherapy for high-risk disease after surgery, but when we are still at high risk of the melanoma coming back and impacting survival. So in terms of immunotherapy, this can be classified into two major parts. We have what we call the passive immunotherapy, where the immune cells, what we call the effector T cells that go after the cancer, are introduced into the patient. These sometimes can be harvested from the tumor. We call them tumor-infiltrating lymphocytes, grown in the lab or manipulated in the lab, and then reintroduced into the patient. And there are studies that show that this is a promising kind of approach of treating melanoma. Although most of the studies and most of the treatments use the active immunotherapy approach. Here we're using agents that stimulate our immune system to produce these effector T cells that go after the cancer. And these include what we call cytokines or immune response modifiers, including interleukin-2, interferon alpha, and other agents that are still experimental. We have the vaccines, which include the peptide vaccines, the dendritic cell vaccines, and the genetic vaccines. And the most exciting field of immunotherapy of melanoma today are what we call immune checkpoint modulators or blockers, which include these agents that manipulate certain receptors or what we call maybe breaks or checkpoints on these T cells and make them work in different ways. These include the anti-CTLA-4, anti-PD-1, and of course, the anti-CTLA-4 is now, we have an agent approved in the clinic by the FDA, peelable. Also, we have interleukin-2 and interferon alpha as approved agents in the clinic, and others are still experimental. I'm going to start with stage 4, and just as Dr. Holtzman described to you, this is when we have the cancer has spread to other organ systems. So the cancer started on the arm here, now it has spread into other organs, and now there is a role for systemic immune therapy or other kind of treatments to go after the cancer systemically, targeting all of these organs at the same time. So in terms of FDA-approved agents outside of clinical trials for metastatic melanoma, we have dacarbazine, which is chemotherapy approved more than 40 years ago, and which has some activity but has never shown to actually prolong life or improve survival of patients. We have high-dose interleukin-2 and ipilimumab, which are classified as immunotherapy. And we have the newer targeted agents, such as vemurafenib, dabrafenib, and trametinib. Now, in terms of what is the underlying rationale to use immunotherapy, there is a widely accepted hypothesis called the Immunoediting Hypothesis, which says that by the time the cancer is clinically detectable, this cancer has passed through several phases, and now it has learned to evade the immune response. So the immune system looks at this cancer as probably part of the body, and that's why it survives and proliferates and continues to spread into other organs organs. And therefore, the role of immunotherapy is try to reverse this process and go back to what we call the phase of elimination, where the immune system can now get rid of the cancer. Starting with high-dose interleukin-2, this is an agent which was approved by the FDA in 1998. Interleukin-2 is a cytokine present in our body that has a central role in regulating the function and growth of the major elements of the immune system and in manipulating several aspects of the immune system to go after the cancer. The way we give high-dose interleukin-2 is in the hospital. It has to be given intravenously over a period of about 5 days. The patients get a rest period for about 2 to 3 weeks, and then they go back for another cycle. The data, the studies that tested this agent, high-dose interleukin-2, have shown that the response rate, the ability to shrink the tumor with interleukin-2 is about 16%. These could either be partial responses or could be complete responses where the cancer completely disappears. One thing about interleukin-2 is about 5% of these patients tend to have these long, durable responses that go beyond 10 years, which is the closest we've seen to a cure potentially for melanoma. So although in a small subset of patients, it can actually eventually work. Of course, this is promising, but it's not enough, and therefore we've embarked at trying to build on this promise of interleukin-2. And recently we have learned that there are potential predictors of benefit from interleukin-2, and a study have shown that a growth factor in the blood called vascular endothelial growth factor, if it is low, these patients have a higher likelihood of responding to interleukin-2 and a higher likelihood of surviving longer after being treated with high-dose interleukin-2. And I know this is a complex slide, but basically illustrates a central role for this growth factor, vascular endothelial growth factor, VEGF, in actually mediating immune suppression and inducing and recruiting certain elements of the immune response that suppress the immune system, so-called regulatory T cells, myeloid-derived suppressor cells. In addition, this vascular endothelial growth factor, or VEGF, has the ability to induce what we call blood vessels, or a process called angiogenesis, that may supply the tumor. And therefore, blocking it makes sense, both as for its anti-angiogenic activity and possibly for reversing the immunosuppressive activity mediated by this agent. And now we have agents that can suppress VEGF or completely eliminate it from the clinic. So this agent called Flearecept here, it's a receptor that can bind to VEGF and basically eliminate it from the blood of the patients. We tested it in a study that we published in Clinical Cancer Research, and have shown promising activity in terms of preventing the progression of the cancer and of prolonging life of these patients. For example, the 1-year survival was about 58% with this agent versus what we predicted without this agent would be about 36%, let's say, with chemotherapy. So now we have a study in the clinic which is combining interleukin-2 based on these data, based on this rationale. So high-dose interleukin-2 plus this agent versus high-dose IL-2 alone. This is a study that plans to treat about 105 patients. We've treated over 61 patients to date. The immune checkpoints. This is, as I said, it's an exciting field. Dr. Zarour will be discussing more about this topic later on, primarily mostly about the anti-PD-1 antibodies. But to make it simple, how do these agents work? So the process of activating these effector T cells that I mentioned, these are the T cells that go after the cancer, goes through two major phases. We have the priming phase, where we have interaction between the T cell and so-called antigen-presenting cell, which presents certain antigens or proteins from the tumor cell to the effector T cell, to the soldier, to educate it against the cancer. It then goes on and exercises its what we call cytotoxic activity against the tumor cells. So at the level of this priming phase, this interaction between the dendritic cell or antigen-presenting cell and the T cell, we have the presentation of the antigen here to the T cell receptor activating the T cell. We need another stimulus which binds this protein called B7 to another receptor called CD28, and now we have full activation of the T cell that recognizes the tumor and can go after the cancer. However, by nature, we cannot have overactivity of the T cells. So we have inherent activity to kind of suppress the overactivity of the T cells to avoid autoimmunity or autoimmune diseases. But if this is an anti-tumor T cell, this may work in favor of the cancer and suppress an activated anti-cancer T cell. And this is where we have this upregulation of a receptor called CTLA4 that binds to this protein called B7 and now inhibits this T cell. With the antibodies that block CTLA4, such as ipilimumab, which is now approved by the FDA since 2011, we're blocking this suppressive defect, this CTLA4, and allowing the T cell to go and attack the cancer. By the time it reaches the cancer cell has its own resistance mechanisms. It upregulates another protein on its surface called PD-L1 that binds to another suppressive receptor called PD-1 and again inhibits the activity of the T cell. And what we have in the clinic today as part of the clinical trials, the anti-PD-1 antibodies and the anti-PD-L1 antibodies, which have shown great promise in the clinic, and we're very excited about these. We see now response rates between 30 to 50% in shrinking the tumor that are most of the time durable responses that go on for several months and beyond a year. And it is a rapidly kind of evolving field, which is very exciting, and Dr. Zarour will be talking to you about this in more depth. So as an analogy, one of our colleagues, Jed Wolchok at Memorial, has made this interesting analogy to better understand how these agents work. For example, the binding of the dendritic cell, what we call MHC antigen complex, to the T cell receptor is like the ignition turning on the T cell. And then when you have this second stimulus, binding of this protein B7-C28 is like hitting the accelerator. But then we have the CTLA4 upregulated here, it's like hitting the brake. So you have a T cell knows the tumor, but now it doesn't work. So blocking the CTLA4 allows the T cell to go and do kind of releasing the brake. So we had two phase 3, what we call phase 3 studies, larger studies, which compared ipilimumab, the anti-CTLA4 antibody, to other agents and now demonstrated its activity. The first study tested this ipilimumab with a vaccine, with a peptide vaccine, a protein, which is a part of a protein. A peptide is a part of a protein, and either looked at this ipilimumab in combination with placebo or with this vaccine versus the vaccine alone. The second study combined the ipilimumab with the standard chemotherapy agent called dacarbazine and compared it to dacarbazine alone. And with both studies, we have seen significant activity and the prolongation of survival of these patients, those who were treated with the ipilimumab, and this led to the approval of the ipilimumab by the FDA. Of course, when we're releasing this brake, now we have overactivity of the T cells, overactivity of the immune system, and this is where we see the side effects, which what we call autoimmune side effects or immune-mediated side effects, causing skin rash, an inflammation of the bowel, which may lead to a significant diarrhea, inflammation of some of the glands. These are the glands that produce hormones, the pituitary gland, the thyroid gland. We have inflammation of the liver, among other toxicities that need to be treated with immune suppressants. These are like steroids or other agents that can suppress the immune system. And these can be significant. And we usually, we talk about this in the clinic. We tell our patients to contact us immediately if they see a rash, diarrhea, not feeling well, anything that bothers them, because these need to be treated very early on. Now what we're moving is into the realm of combinations. We understand these agents, how well they work as single agents, and now the future is combining these agents together, looking into better activity while obviously being conscious and watching the toxicity of these drugs. So there are a lot of studies out there, and there is strong rationale to make combinations with multiple agents, such as interferon alpha, interleukin 2, Flearecept that I mentioned, or other agents that work like it, anti-PD-1, and other immune checkpoint blockers, anti-IDO, also the targeted therapy that Dr. Tawi will review. And what we did is we went on and did the first combination study actually in this place, which is combining an anti-CTLA4 antibody called the tremelimumab, works like ipilimumab, with interferon alpha. And what we found is we had very promising activity. We have seen a high response rate, which was actually about 24 to 26%, with responses that were durable. And we had a number of patients that are now disease-free for several years. We went on and took this study into another national study that is currently ongoing and combining interferon alpha with ipilimumab, the anti-CTLA-4 antibody, looking at 2 different dose levels where we're looking into not only the activity but also the toxicity and what makes sense eventually to bring into clinic to treat our patients. Of course, we have now Dr. Zarour will present the anti-PD-1 antibody concept, but the studies are very promising with anti-PD-1 antibodies. As I said, we have response rates from 30 to 50%, and now we're moving into combinations and the future generation of these studies. Now, high-risk disease. These are patients that were presented by Dr. Holtzman that had surgery, but now are at high risk of cancer recurrence, that the cancer may still come back. And if we estimate the risk of it coming back, may range between 40% or more within 5 years. And we have 2 FDA-approved agents, the high-dose interferon alpha and the pegylated interferon alpha. As Dr. Holtzman presented, patients with stage 2, these are patients with either deep tumors or have certain features called ulceration or high mitotic rate that make them high risk of coming back. And these could be classified as 2A, 2B, and 2C. Mostly, we treat those who are 2B or 2C. These are the ones which are a higher risk of the cancer coming back. 2A, we call them intermediate risk. We don't have evidence now that if we give treatment would actually in the best interest of the patients. Stage 3, this is when the cancer spreads into the lymph nodes. So the cancer starts here, spreads into the lymph nodes. These are stage 3. They could be 3A, 3B, and 3C. All of these should receive adjuvant treatment. Now the standard of care obviously is interferon alpha, but the studies are looking into other agents. So this is a complex table, and I apologize for that. But basically what I'm trying to summarize here, the first 3 studies, which were led by Dr. Kirkwood and tested the high-dose interferon regimen that is now obviously approved by the FDA since 1995. And it is currently what we consider as the most effective agent or most effective regimen for the treatment of what we call high-risk melanoma after surgery, and it's given over 1 year. Recently, we have approval of pegylated interferon, a regimen which is given subcutaneously weekly up to 5 years. And it has shown activity and impact on what we call relapse-free survival, so preventing the cancer from coming back. But we haven't seen activity in terms of improving life or overall survival, something that we did see in the prior studies that tested the 1-year high-dose regimen tested in these 3 US ECOG and intergroup studies. When we look closer at the new study that tested the pegylated interferon, this study enrolled patients and divided them into 2 groups. The first group, they call them N1, which is microscopic involvement of the lymph node. When you have a sentinel lymph node and you find pathologically it has melanoma, they called it N1. And the second group was called N2. These are patients where you can palpate the lymph node, you can feel it, you can see clinically when you do the examination that they have cancer. So for the N1 population, microscopic involvement after sentinel lymph node, there is improvement in relapse-free survival, preventing or delaying the recurrence of the cancer. But there was no improvement in terms of overall survival, prolonging life overall. It wasn't seen as reported on the study. On the other hand, when we look at the N2 population, when the cancer is bulky, and you can feel it, you can palpate the lymph node, there was no what we call a statistically significant impact. There was no clear difference between those who were treated with this regimen or those who got simply observation. And therefore, what we do in clinic today is we offer these patients the high-dose 1-year regimen. This is our practice here. And if they tell us for some reason they do not want, the high-dose regimen has an IV part of it, so we have to do 5 days IV, Monday through Friday for 4 weeks, then we offer the second regimen for those who have microscopic nodal involvement. There are a lot of ongoing studies now in the adjuvant setting that are comparing, that are looking into new options for these patients. There is a vaccine study called DERMA trial, which unfortunately recently announced that they did not meet their primary endpoint of delaying the recurrence of the cancer. The study continues to be followed because they're also looking at a gene signature. They do a gene expression test at baseline, and they'd like to see if this gene signature can predict who should be treated with this protein vaccine. So it's still being followed. The second study tested high-dose ipilimumab at a higher dose than what we use now. The dose is 10 milligram per kilogram versus placebo. It's still blinded, still being followed, and we may be able, it's possible that we will hear something in the next few months. The next study is the Intergroup 1609, which was designed in this place, and we're leading it out of Pittsburgh. It's an international study that is treating patients with ipilimumab at the high dose of 10 milligram per kilogram, the standard dose of 3 milligram per kilogram, and we're comparing them to the current standard of high-dose interferon. This study is still ongoing as well. The number of patients enrolled to date is about close to 1,200 patients out of the 1,500 planned. So hopefully we will be able to complete the study in the next few months, and then we obviously will wait maybe for up to 2 years to find the final results. We have adjuvant studies with targeted therapy that Dr. Tawi will review, and now we're designing the next generation of studies with anti-PD-1 antibodies. This is a study that's going to be a collaborative national study that we hope to activate in the summer of 2014. Now, a very important question is, we all know, all of us know, that when we treat our patients, not all of them respond. And the question is, are there certain factors or markers or blood tests that we can do who can tell us who are the patients who are at high risk of cancer recurrence and therefore should focus the treatment on them, or those certain markers who can tell us this patient has to get this treatment, and this patient has to get that treatment. So this is the difference between what we call prognostic markers and predictive markers. And this is a major field of interest by our group here, and we've done a lot of work in this regard. So we designed a study a few years ago where we looked at ipilimumab, and we took a tumor biopsy before we gave ipilimumab in patients where the cancer is bulky but still operable. We can remove it. We gave them ipilimumab for 6 weeks and then did the definitive surgery. So now we have samples from the blood and samples from the tumor before and after treatment, and this allows us to look at the same time simultaneously in the blood and the tumor and try to look into these potentially predictive biomarkers. We were excited with the number of findings that we found, and this led us to design a major project that was now funded by the NIH earlier this summer as part of the Skin Spore grant application here. And this is looking in the larger 1609 study, the big adjuvant study of 1,500 patients. It's going to look into these biomarkers both in the blood and the tumor, and hopefully we are optimistic that eventually we will come up with a biomarker signature that can narrow down the number of patients that need to be treated with these agents. We moved on to the next generation of these new adjuvant studies. So now we're testing the combination of ipilimumab and interferon, and we're designing the next new adjuvant studies with anti-PD-1 and so on. So I'd like to thank you for your attention.